daughter that she delivered. Her name is Sailor Marie. So let's talk a little bit about what happens immediately post-delivery. So we talked about mom and what we did for her, so let's talk about what we're gonna do for baby. So once the baby delivers, the first thing that you're gonna see the physician do is they're gonna clear the airway. So you're gonna use the bulb syringe and they're gonna clear which first, mouth or nose?
Nose.
Mouth first, then nose, with the bulb syringe. They're gonna open up the airway. The second thing that you're gonna see them do is something called dry and stimulate. Dry the baby off so they don't lose a lot of body heat, stimulate the baby to cry so they open up their lungs because, mom's been doing all the work and now they gotta do it themselves. So that's gonna not really be considered resuscitation, that's just standard of care, okay? So clear the airway, dry and stimulate. All babies are gonna get that. Everybody good with that?
Yep.
Once that happens, the first mini assessment that we're gonna do on that newborn is gonna be something called an APGAR score. So we're gonna do that at 1 minute and 5 minutes for all babies, even if everything's perfectly fine. If we are having to resuscitate the baby, we will continue to do APGAR scoring every 5 minutes until the baby's either unfortunately deceased or until the baby is stabilized, okay? So the only babies that are gonna get additional APGAR scores are the ones that we're actually having to do some interventions on. Most babies just get 1 and 5 minute APGARs, because usually everything's okay. So just to kind of recap, Sailor Marie was 9 pounds and 3 ounces. Her mom was gestational diabetic. She did have a moderate shoulder dystocia, so we need to make sure we're monitoring that arm to see if she's using it and everything looks like it should. Make sure we don't have any nerve damage or a clavicle fracture. And we're gonna go ahead and do her APGAR scoring. What else do we need to monitor closely in her because her mom was gestational diabetic? Hypoglycemia, so her blood glucose. She's a big baby, her mom was gestational diabetic, we know she has a high risk of hypoglycemia. For testing purposes, I will not give you this scoring system. This one you do have to know, okay? Telling you up front, most things I'll give you, but this I'm not going to. So this is how I remember it. When you get your scratch paper, you can go ahead and write down the acronym APGAR. And you have an option of 0, 1, or 2. 2 meaning they're doing it exactly like they're supposed to. 1 meaning they're doing it, but not exactly like we want them to. And 0 meaning they're not doing it at all. Okay? So based on your findings, you need to be able to calculate an APGAR score. The other thing that's really important to note is that the activity or muscle tone and the grimace, which is reflex irritability, go hand in hand. If you give one score on one, you're gonna give the same score on the other one. Okay, those are gonna go hand in hand, which will help, because that's usually what's confusing. So, wanna practice one?
Sure.
So she delivers, we dry and stimulate, we clear the airway, she is placed on mom's chest, and we're doing our 1 minute APGAR. These are your findings on the board. See if you can calculate your APGAR score. Don't yell it out, just kind of calculate it, and then we'll go through it. Ready?
Yes.
All right, so what are we gonna give her for activity?
2.
2. Pulse, we're gonna give her
2.
grimace, we're gonna give her
2.
Okay, appearance or
1.
color
1.
1. And then respirations,
2.
that would make her APGAR score 9. Is that an appropriate APGAR score?
I hope so.
It is, absolutely. So usually we like it to be 8 or above, but if it's below 7, then we're gonna be doing additional interventions. And the closer to 0 it is, the more interventions we're gonna be doing, okay? So I'm not gonna spend any time, or really a lot of time, on neonatal resuscitation. That is more 211 high risk stuff next semester. But there are a couple things that I do want you to know. So 9 times out of 10, 99% of the time, if we have a newborn that is not doing what they're supposed to, it's a respiratory issue. Okay? Same is true for pediatrics. Little bitties have lots of respiratory issues. So the first intervention that we're gonna do is, of course, we cleared the airway. We're gonna suction them out, make sure there's not fluid there. And then we're gonna go pretty quickly to something called positive pressure ventilation. We're gonna start giving them some air so their lungs will open up and they can ventilate properly. Okay, so positive pressure ventilation, because most of the issues that we see are gonna be respiratory in nature. The other little addition that I will say is we don't wait until a baby has no heart rate to start chest compressions. We start chest compressions if the heart rate drops below 60. So if you are in the clinical setting and there is a baby that we are resuscitating, you're like, well, it has a heart rate, why are we doing chest compressions? Because if it drops below 60, we're gonna immediately start chest compressions, right? How do we do chest compressions on the newborn? We do not. They're little.
Yeah, I guess you can.
You can do it with 2 fingers.
Okay.
It's
Oh,
usually
that's
more
wrong.
Yeah, you can do it with 2 fingers. We usually do like an encircling chest because we can move a little bit better to give them access sometimes when we do that. But either one's fine, just, not a pump, that's a lot.
Is it because their heart rate will decline from 60 to 0 rapidly?
Yes, and if you think about what their normal heart rate is, if they're 60 instead of 120, that's half of what it should be, right? So they're gonna be decompensated significantly. Usually ventilation will work and we can fix problems that way. Let's try another one. Ready? Activity. One. All right, so because it gave you the flex presentation with active range of motion, they actually give it to you for that.
Oh.
So it just gave it to you separately. It's almost easier if it's given to you together. Like if it had said flex with active range of motion, everybody would have picked 2, okay? So we're gonna give them 2 because they're actively moving, right? Active range of motion. So we're gonna give them 2 for that. Pulse would be 2. Grimace would be 2. Appearance,
1.
1. And respirations,
2.
2. What is your normal respiratory rate for a newborn? 30 to 60. You do need to commit that to memory because it is different than ours. So 30 to 60 is the normal. Now, we have done a 1 minute and a 5 minute APGAR. They were both 9. Can we proceed on with our normal care?
Yeah.
Yes, this baby is stable. We can continue on. So we're never gonna do nothing. So we're gonna document and continue our normal plan of care, which would include the following. Little caveat, if you have a newborn baby and you're performing APGAR, has that baby had a bath?
No.
Where did that baby just come from?
That's bad.
Would you have stuck your fingers in someone's vagina without gloves on that doesn't belong to you or you're intimately involved with? No, right? So you need to have gloves on until that baby is baby, okay? So gloves on.
You should not.
You should not. The answer is you should not. So make sure you have gloves on until the baby has had a bath, which is usually delayed by several hours. So if you're going into nursery and there's a baby under the warmer, don't just touch them with a bare hand, because chances are, if they're a newborn, they probably have not had a bath yet, okay? If they don't have clothes on, they probably have not had a bath yet. Just be mindful of that. Where does that baby go immediately following delivery, assuming that everything is okay? To mom's chest, skin to skin. We want them skin to skin as soon as possible. Unless there is a reason that we need to move the baby to the warmer, we can do APGAR scoring on mom's chest. I will say, be mindful that you do ask, because those physicians will just plop that baby up there, and sometimes it can freak a mom out when that baby is all slippery and got all the vernix on it, and we just plop it on her chest, and she wasn't anticipating that, okay? So just make sure you ask first.
Surely I told my doctor to not put any on it.
Yeah. Wipe her off before you hand her to me. We do get that sometimes, and that's completely fine. But it is standard of care now, just to put them directly on the chest, so just be mindful of that. Alright, we're also gonna check the cord once it is clamped and cut to see if it is a 3-vessel cord. It should have how many vessels?
Two arteries.
2 arteries and 1 vein.
Or 1 and 1.
Or at least 1 and 1. So if it's 2 vessels and this baby is living, then it had to be an artery and a vein. It should have 2 arteries and 1 vein. Assuming, yes,
Why, what's the purpose?
the 2 arteries and 1 vein
If
are
it
just.
had 1 artery, 1 vein.
So if it just had 2 arteries, it would be a closed system and it would have never survived. So it has to have, if it's a 2-vessel cord, you can automatically assume that 1 is an artery and 1's a vein. And they do look different. No.
So
Baby
it's
probably,
just-
it's just for knowledge, because a lot of times
It's
they have
gonna be
growth
smaller.
issues. Yeah, the babies are usually smaller, they have a 2-vessel cord.
Would that
So we
be
do know
something
this.
that you would investigate if the baby was dead?
Possibly, so if it was a stillborn, they may look at the cord, look at the placenta, look at the baby overall, and see if there's any obvious reason, and that could be a.
I just didn't know if they would be viable that long for cord PSS.
Possibly, it would just depend, but yes, we usually do try to investigate as much as we can. Then we're gonna continue on our normal things, so it's gonna be our measurements, our medications, we're gonna put a diaper on the baby so it doesn't poop and pee everywhere, we're gonna put a hat on for heat loss, and we're gonna do all our security things, which is what we're gonna do next. Okay? So for security, before that baby leaves the room, it will be banded with a band that has the same number as mom. So mom gets a band, baby gets a band, and then whoever mom says gets the other band, gets the other band, okay? So if that's the dad, if it's the mom, whoever's gonna be with them the most. So those bands all have the same number. That is the way that we match that baby to that mom. So every time we take that baby back to the room, we should be checking those security bands with that ID band to make sure that it is her baby, okay? Thank God I didn't have it in our facility, but there has been facilities where nurse was gone in, she checks the band, she realizes it's not the baby, it belongs to that mama who is now breastfeeding someone else's baby.
Well, you know.
So check the bands. If mom has twins or triplets, she will get a band for each baby. What we usually tell our moms and our dads, that band stays on your arm until the baby is home with you. So if baby stays and mama goes home, the band stays in place, that's her ticket in and out of the nursery, and they will check it every time she sees the baby. Okay? We will also put a security band on the baby. This one's a little bit outdated, but they do look very similar, so it's the same principle. We call it our little baby LoJack system, so it tells us where our babies are at all times. If it is too tight or too loose, the family needs to let us know, because if they pop that band, guess what's gonna happen? Everything's gonna alarm, you're gonna see lots of extra faces in your room, so don't pop the band off. That security band is the last thing that is removed before they go home. So once they are discharged, they're in the car seat, then we'll remove the security band. Any questions about security? No? Measurements and medications. Let's cover measurements first. So all babies are gonna get a length, a height. I'm just kidding, that's the same thing. A length and a weight. And all babies are gonna get a head circumference and a chest circumference. So let's talk about head first. The head circumference is gonna be measured at the brow line. The chest circumference is gonna be measured at the nipple line. The weight is what it is. Okay. The length is gonna be the tip of the baby's head to an outstretched heel. So yes, if that baby has a cone head, it's gonna be a little bit longer today than it is tomorrow, and that's okay too. Right. The tip of the head and to an outstretched heel. The one that may or may not be done is gonna be the abdominal circumference, which is usually measured right below the belly button. That is routinely done for your premature babies, but it is not always done for your full-term babies. Your preemies have a lot of risk for GI issues, and it's really hard sometimes to tell if you have abdominal distension in a newborn. So it's a objective way to see if they have abdominal distension. So it may or may not be done in your full-term babies, but probably will be done for your preemies. Any questions on measurements? Your head measurement and your chest measurement should be pretty similar. You shouldn't have any major discrepancy in those two measurements. There are 3 medications that we routinely give in that postpartum or that post-delivery period. The first one is gonna be the erythromycin ointment. That goes in the baby's eyes and the lower conjunctival sac, so half the tube in one eye, half the tube in the other eye. Make sure you don't touch the eyeball itself. This is to prevent infections specifically like chlamydia and gonorrhea that they could potentially come in contact with. It does not mean that your mom has gonorrhea and chlamydia. We do it for all of our babies. It is state mandated, so if the mom wanted to decline that, there would be some paperwork that she would have to sign to refuse that. Okay? It does make their eyes look really gumpy, so if it's a first-time mom, make sure you tell them, because it looks like their eyes are draining, and that can be worrisome to a parent. So just make sure that they do know that that is what that is. The next one that is also state mandated is the vitamin K injection. It's an IM injection. Why do we give vitamin K to our newborns?
Because they don't need anybody.
The Cause until they start and have their own like GI biome, they're not gonna be able to produce it. And so we give them a one-time shot that's gonna cover them. So it helps to reduce their risk of significant bleeding issues in that newborn period. So one shot will cover them until they start producing enough of their own. This one has been in the news a good bit here lately. It's been one that we've had to fight a little bit more for with some of our parents, and I think some of it is because it's an injection, they assume it's a vaccination. It is not, it is just a vitamin K injection, that's just how we deliver it. There is an oral form of vitamin K, but the baby's GI tract is very erratic, and it's very hard to get significant amounts absorbed in their GI tract, because again, for the same reason, they're not producing their own, okay? The other thing that I've seen a lot on TikTok here lately is, well, I'll just breastfeed my baby, that's gonna give them enough vitamin K. Some will cross in the breast milk, but it is very, very small amounts, so it's not adequate amounts. So that's another thing that we're kinda having to fight with some of that education that we do. They can refuse it, but that would require some additional documentation, because this one is also state mandated. The problem is, if they don't get it and they do have significant bleeding, what we typically see, and although it is rare, it is usually life-threatening when it happens, is brain bleeds. So they go home, they come back in after they've been discharged with some type of issue, we do a scan, they have a massive brain bleed, and once they have a brain bleed, there's not even anything we can do about it. So it is preventative for that.
State mandated for the hospital to give?
Yes.
Oh, okay.
Yeah. So if they wanna refuse it, we've had one in the last week or so that wanted to refuse it, and it ended up having a vacuum delivery, and so they encouraged it, and I think they ended up going back and giving it, which is great, cause that's a great thing.
So you still working there with me?
I don't know, I'm just there for clinicals now, but I did work PRN up until about a year and a half ago, so, yeah.
I thought you were still doing work, I said, you go supervise.
No, I need to go back and do it, I do miss it, but, no, I just do clinicals there. Alright, so that is your erythromycin and your vitamin K, that is the, generic name for vitamin K, by the way, it looks nothing like vitamin K, but Vertigo, that is it. The other medication that we sometimes give is the hepatitis B vaccination. So if they wanna start their shots while they're in the hospital, we will give their first dose of hepatitis B. They can decline that, we usually just have them sign that they'll, if they decline it, they do not want it. And they can follow up with their pediatrician and have a conversation about staggered doses or whether or not they wanna give it. So hepatitis B, they can refuse, there's not really any issues with that, but if they wanna refuse the erythromycin or the vitamin K, we can require them to sign a refusal form for that. That essentially says these are the risks and benefits. Okay. Those are IM injections. Where is your primary site for an injection for a newborn? Vastus lateralis. And what gauge and length of needle would be appropriate for a newborn?
3/8 inch.
Okay, 3/8 to 5/8 I would take for length, and then for, as far as your gauge, probably 23 to 25, 25 to 27, somewhere along in that range. You want a small needle that is short, you're gonna give it the vastus lateralis. We typically give one injection in each thigh and then document what we gave where, so if there is a reaction, we would know what they had a reaction to. Measurements and stuff. Alright, so it has been 1 hour since delivery, and Sailor has the following vital signs findings. She does have some acrocyanosis, and her glucose is 42. Red flags or issues?
But it's not.
Okay, so the newborns do have a different range than us, so we're gonna say, so that we're consistent, less than 40 is when we're gonna do intermissions, okay? Well, we are close to that. What do we think about vital signs? I would love for her temp to be a little bit higher, because that is axillary, so it's probably slightly lower than that. So we're gonna put her skin to skin and allow her to breastfeed, which fixes hopefully our glucose and our temperature issue, okay? So we do that, and it has now been 3 hours later. You go in to do a routine assessment, you note the following: dad is holding the infant, showing her off to the family. Her respiratory rate is 62 breaths per minute, her axillary temp is 97.2, and the infant is crying and jittery.
The baby need to go back to the one in person.
What would I wanna check?
She's like,
Okay. So her glucose is now 36.
Now
So
she
she's
had to do-
symptomatic, now we got a problem, right? So what do we do?
She's symptomatic, so you might have to give her glucose.
Okay. So our options would be let her latch and let her feed and recheck it quickly after to see if it's coming up. Or if we cannot get her to latch or for whatever reason she can't eat, we could give glucose, okay? So we're gonna put her skin to skin, we're gonna stay in there while she breastfeeds, and we're gonna reassess. So here's the key that I want y'all to know. There's a lot of reasons that we can have issues with our baby. Hers may be hypoglycemia, it could be something else. So anytime you see a baby that is crying and jittery, it's telling you something. Specifically, if it notes that it is a high-pitched cry, okay? So let's talk about some other symptoms. I do realize that apnea is misspelled. This was a slide that I pulled from somewhere. So I'm gonna key you in on the things that I want y'all to know as far as hypoglycemia. What is your baby gonna present with? High-pitched cry. Okay. Starting from the top, apnea is what?
Not breathing.
They have periods where they stop breathing. It's not for long periods, it's usually for several seconds, but they have a weird breathing pattern. So you can see apnea, you can also see cyanosis when they become hypoglycemic, and jitteriness is a big one as well. They're very shaky and jittery, just like you would be if your blood sugar dropped. What does the term hypotonia mean?
Is that without oxygen?
Decreased.
They're floppy, for lack of a better way to put it. A happy baby is gonna be in this nice tight fetal position. We don't like floppy babies. So hypotonia, meaning that if you were to grab their arm, it's just gonna kind of flop around, it's not gonna resist you, okay? So floppy babies are not happy babies. Those are the ones that I want y'all to know. Now, you can have seizures, but hopefully we have caught it before you get to the point of having a seizure from a low blood glucose. So what is our range? We're gonna want it above what? 40. So less than 40, we need to be intervening, or if we're getting close to that 40 range, let's go ahead and put the baby to rest so that hopefully we don't have any issues. Okay, so we do that. We feed the baby. The glucose comes up, but the baby still is not doing what we need to do. Still has a high respiratory rate, still isn't quite as warm as we would like for it to be. So now we're gonna look at other reasons we could be seeing this, okay? So now we've talked about hypoglycemia. Let's talk about some other complications that we can see in the newborn. First, we're gonna start with cold stress. So we breastfeed, we come back in 30 minutes. The glucose is now 51, but the respiratory rate is now 70. The temp is now 97.0. And now we think we have a little bit of something else going on. So the first thing we're gonna talk about is cold stress. So cold stress is where the baby's temp drops and it causes respiratory distress. So let's talk about your signs and symptoms of respiratory distress. If you learn nothing else about newborn, I hope that you can identify a baby that's in respiratory distress before you leave class today. So what are some symptoms that we would see in a newborn that could tell us that they are in trouble? Retractions, nasal flaring, grunting. Parents think it's cute, the nurse is like, I don't like that. All right, so nasal flaring, grunting, and retractions. What would happen to their oxygenation level if we checked it? It would be low. What coloration could we see? So not just acrocyanosis where their little hands and feet are blue, that's somewhat expected. You would see central cyanosis. Their lips are pale, their lips are blue, their trunk is kind of pale. That's gonna be more consistent with respiratory distress. What's gonna happen to their respiratory rate? It usually goes up. So they're gonna be tachypnic or have a high respiratory rate. Now eventually it may be low, but initially it's gonna be high. So those are the things that you're looking for. One thing that I do want you to note on this slide is that cold stress can lead to, what did I say? Metabolic acidosis. This would be a fantastic way to pull back in some 113 ABGs, just saying.
Not respiratory.
Not respiratory, metabolic. Okay?
Are those levels consistent with adults?
Yeah, if they are very consistent. I usually use the adult ranges. They're very similar. Okay? So that's cold stress. Warm them up, give them respiratory support, fix the problem. Ready with that? The other complication that we can see is something called transient tachypnea of the newborn. So we typically see this in our C-section babies, but I needed to cover it, so it's put on the slide. So transient tachypnea, for a baby that is born vaginally, they come through the birth canal, they get squeezed, so all that extra stuff that's in their lungs, because remember they're floating around in amniotic fluid, there's amniotic fluid everywhere, is gonna be squeezed out. So your vaginal delivery babies typically don't have transient tachypnea of the newborn. It's gonna be much more common in your C-section babies, because they don't get that squeeze, because they're just delivered through the little sunroof, and so they don't get squeezed, and so they can have some extra fluid in their lungs. So it is not uncommon for lungs of a C-section baby to seem a little wet, have a little crackle, because they still have some fluid in there. But they are gonna be at risk for some respiratory issues until they clear that fluid. So they may be diagnosed with something called transient tachypnea of the newborn. They may have to come to the NICU, be placed on a little oxygen until they can transition and get that fluid out of their lungs, okay? Most babies will transition just fine. They come to us for an hour or so, we do a little suctioning, we give them a little oxygen, it clears, and they can go out the room with mom. If it is continually getting worse, then they would look for additional reasons that it could be happening, okay? Back up. So we have now talked about complications, we've talked about hypoglycemia, we talked about cold stress, and we've talked about transient tachypnea of the newborn. Very good. So we bring a sailor to the nursery just so we can kind of watch her. We put her under the warmer, we give her a little oxygen, we check some oxygen saturations, and she settles down. She was probably just cold, we warmed her up, gave her a little support, she did fine. Well, let's talk about a few things. Do y'all know what this probe right here is for, this little attachment? It's okay if you don't, it is a temp probe. So if we put them in our open warmer, we're gonna put that temp probe. The ideal place to place that is gonna be over the liver, which is the right upper quadrant. You may see it other places, but that's the most ideal hospital utopia place, which is where that one is. And it's gonna connect to our warmer so that it will warm up or cool off based on her temperature, okay? What is this right here? O2 saturation. So let me kind of go over that. Now she's several hours post, so she should be a normal O2 saturation. Immediately following delivery, they are not at 100% when they come out of mom. If you've ever seen a baby deliver, like kind of blue, a little worrisome sometimes. It takes about 10 minutes after delivery before we expect that their oxygen saturation is 90 or above. So if we're doing some interventions and we place an oxygen probe on the baby's finger, or on their wrist is usually where we put it, it may not be 90 and that may be okay. Once they get to that, we hold them to that standard. So it can take up to 10 minutes. So usually between 9 and 10 minutes post-delivery, their O2 sat is between 90 to 100. Yes?
Is that related kind of to the acrocyanosis sort of deal, like it's a
Yeah, so
perfusion
it takes
issue?
a little time for their body to kind of say, oh, you want me to do all the work? Mom's been doing it for me. So it does take a little time. Now, obviously, if we're doing resuscitation and we add oxygen, it's gonna hopefully come up quicker, but that is gonna be standard for a baby that's not getting oxygen. Okay? Ready to go for that? What is this? Nasal cannula for a baby.
That's cute.
It's so cute.
Not that I want.
I know, not that we want that, but. Alright, so she settles down, it's now been an hour, these are your new vital signs, tell me what you think. No, probably
I don't know.
Everybody on the day cohort was like, I don't know what the blood pressure is, I don't know what the normal is.
Pediatrics are usually low, but I don't know about
Yeah, that is okay for this baby, it's fine. I'm not gonna ask you about blood pressure so much on the
because
test.
they don't usually.
They don't typically have blood pressure issues. But for testing purposes, you do need to know what their normal respiratory rate and heart rate is, for sure. So looking at those, what do we think? She's good. Temp looks better, so we're gonna go ahead and do our head to toe assessment and our other things that we need to add into this lecture so that we cover everything. Let's talk a little bit about gestational age assessment. So we know that when a mom comes in, we most of the time know how many weeks she should be. The gestational age assessment is a physical, assessment of how that baby looks versus how many weeks the labor and delivery nurse said it was, okay? So, she said she was 39 weeks, does this baby really look like and act like a 39-week baby? So gestational age assessment. You'll cover this a little bit more next semester, because it kind of comes more into play when you have premature babies, but I'm gonna talk about a few little differences that you might see with your parents. What is the white cheesy stuff that's on the baby's skin? Vernix. What is the hair that they have? Lanugo. Okay? So your premature babies are gonna be much more cheesy, and they're gonna have lots of little fine hair all over their body. Your premature babies are also not gonna have great muscle tone. So if you go in the nursery, I can look at two babies and tell you which one's the preemie. Because the full-term baby's gonna be like this, and the premature baby's gonna be laid out like they're sunbathing, okay? So they do have, they have some hypotonia, for lack of a way to put it. They're a little bit floppy. Just a little bit floppy. They're also not gonna resist you. If you take a full-term baby's arm and you try to pull it, they're gonna pull back from you. A preemie, probably not. They're just gonna let you do whatever. You can wrap it around their head if you want to, okay? Your full-term babies may have skin that is peeling if they are post-dates, and they're not gonna have as much vernix. Okay? We're also going to do a hip assessment. Some of this is done by the healthcare provider and some's done by the nurse. I'm just gonna cover it all together. We do look at their hips to see if there's any obvious abnormalities. One of the things that the nurse might notice is uneven skin folds in their thighs. This was also a topic that was covered in 113. There's a lot of bringing some topics back up. And then the healthcare provider will do a Barlow's and an Ortolani's maneuver to see if they can make that hip dislocate. Okay? I've got a picture of that in a few minutes, so I'll cover the treatment when we get to that. If there's any abnormal skin folds or we suspect that there is a congenital hip dysplasia, that would need to be notified to the healthcare provider.
Do they do radiographs?
Yeah, and then they'll usually, he can usually tell just by maneuvering if it is a congenital hip. One thing I do want to note is if that baby is a frank, especially frank breech babies have a higher incidence of congenital hip dysplasia. So frank breech, it's kind of funny. Frank breech babies come out, their booty is down, and so their legs are like this. And so they come out, their legs are like this, and you move it down and it goes click, okay? That hip has had a lot of stress on it. And so it may not have the strength in that hip muscle or that hip joint to hold it into place. So breech presentation does predispose them to having some hip dysplasia. Then we're gonna go ahead and do a head-to-toe assessment looking for any obvious abnormalities. We're gonna check the palate on the inside of the mouth. We're gonna do a physical assessment to see if there's any characteristics that are outside of the norm. When I think about this, I always think of Down syndrome and characteristics you can see for that. They're gonna look for hernias and anything that would just be obvious in a head-to-toe assessment. And then they're also gonna do a neurological assessment looking specifically at the reflexes that we expect to see. And there's a lot of them. I'm just gonna pick the ones that we see most frequently tested, and that's the ones that are gonna be responsible for the test. So we're gonna go through those. The first one is the Moro reflex, M-O-R-O, also known as the startle reflex. If you've ever seen a baby, if there's a loud noise, they kind of jump and shake, that is a startle reflex. It should be present at birth. The other one that we're going to talk about is one that gives you the cute pictures. Baby's hands here, you put your finger in it, what do? They grab it. That is called plantar grasp. Next one is Babinski reflex. So this is the one, if this was the heel of their foot, you're going to do an upside down J. For an adult, flaring is abnormal, but for a newborn, it is normal. So you would expect to see their toes flare out. Okay? So upside down J, moving from the heel to their big toe, and their little toes will go click. The next one is the rooting reflex. So if you are to take the baby's cheek and scratch it, it stimulates them to turn their head and do what? Open their mouth. Because if they're breastfeeding and their nipple touches the side of their cheek, they're gonna turn towards that nipple and open their mouth, rooting reflex. You will probably also see the nurse take a gloved finger and place it in the newborn's mouth to see if they will suck on their finger. That is known as a suck reflex, and it is usually seen after 32 weeks gestation. It is part of the reason that our premature babies have such a hard time eating, because they don't have an effective suck reflex if they're really early. Those are the ones that you're responsible for now. Okay? Everybody good so far? Talk about some complications. First one we're gonna talk about, caput secotium, we just call it caput for short. Caput is gonna be defined as soft tissue swelling that is gonna be kind of all over the head. It does cross a suture line. The reason we typically see caput is a baby that has been in the birth canal for a while, or it's been a really long labor, and there can be just some generalized swelling to the soft tissue of the scalp.
You say does or doesn't cross the suture line?
Does cross the suture line. So caput will cross the suture line, it's gonna be defined as soft tissue swelling, often seen from long labors or difficult labors. Not really anything other than we just note it, we watch them closely, but usually there's no long-term issues from caput. The one that is a little bit more concerning is called cephalohematoma. And obviously with hematoma, you're gonna have bleeding or bruising up under that skin or under that scalp tissue. These are going to not cross a suture line. Your cephalhematomas are gonna be unilateral on one side or the other. So suture lines are where those plates in the head kind of overlap. It will not cross the suture line. It's gonna be one side or the other. These do have a higher incidence of having some issues. They're often seen with a vacuum delivery, so if we had to use like a vacuum assisted delivery device, they can have a higher incidence of cephalohematoma, which makes sense because it's basically like a suction cup that we are sticking to the head and then pulling. So for that reason, we have a lot of restrictions on how we use vacuum assisted delivery devices, how many times a physician can place it, how many pulls they can have on it, and this is why, because it can cause a cephalohematoma. If they have a cephalohematoma, they're also gonna be at higher risk for jaundice. So if you have a baby that was delivered by, like we call ours, or Kiwi, that's the brand name, a vacuum device, then we know we need to monitor them to make sure they don't have a cephalohematoma. And if they do have one, we also know that we're gonna monitor them closely for jaundice. So you can see on this one, the caput's just kind of all over, but these are obviously unilateral, right? The picture on the far right is gonna show what the nurse would typically pick up on if there's a congenital hip dysplasia. You can see that the skin folds are uneven and there's some differences in the knees if you're bending them up. So that would be what the nurse would typically notice. And then the physician would do the Barlow's and the ortolani's, okay? I'm not gonna ask you on test which one's which, I'm gonna tell you now just so you know. If either one of those tests are positive, that is consistent with a congenital hip, but I will tell you what we're testing. So ortolani's is gonna be where they abduct the hip out. It's looking specifically for an anterior dislocation of that hip joint. So abduct the hip out, looking for an anterior displacement. With Barlow's, they put downward pressure and it's looking for a posterior displacement of that joint. For testing purposes, if they have a positive ortolani's or Barlow's, that is consistent with congenital hip. And let's see if y'all can pull back up to 113 content. What is the treatment that we typically do for congenital hip? First line. Okay, spica cast would be second line.
It's the brace.
Yeah, the Pavlik harness. So they'll put them in that Pavlik harness, which holds that hip in the socket, and hopefully that will allow it to strengthen and be able to hold it in place. But the secondary treatment option would be a spica cast. Any questions? We also need to talk about jaundice. So there's two types of jaundice that you need to know. There is pathological and physiological. Pathological and physiological. If you had to guess, which one is worse? Pathological. So pathological jaundice is often present at birth or within the first 24 hours. The most common reason that we see pathological jaundice is gonna be because mom did not get a Roviam injection with a previous pregnancy, and there's been some cross there, some RH incompatibility. So pathological is gonna be seen at birth or shortly after within that first 24 hours. Physiological jaundice is usually seen around 48 hours or after, and I hate to say it's normal, but it's the kind of jaundice that we see a lot. It's a common type of jaundice. And it's related to the fact that the baby's having to do some of the work and the liver's immature. So it has trouble breaking down the bilirubin. The reason you see more jaundice with a cephalohematoma is because the body's having to break down those red blood cells that are sitting in that hematoma, and that's gonna predispose them to having jaundice. So patho usually seen at birth or within 24 hours. Physiological are gonna be seen at 48 hours or later. So about when they get ready to go home, they all of a sudden look like they have this beautiful olive complexion that then turns a little yellow. Okay? So we do routinely screen them for their bilirubin levels, and we would intervene if needed. So the things we're gonna do if they do have jaundice. We wanna make sure they are feeding and pooping. And then we're gonna put them, if needed, on phototherapy. There's two different forms. The one on the right is like a little pad that lights up and you wrap it around the baby. They don't have to have sunglasses on for that one because it's contained in that wrapping. We don't see that one used as often, but that one you just wrap it around the baby and they can stay at mom's bedside. If we were putting them under the phototherapy lights, they're usually in the nursery under the warmer, and this is what we traditionally see, right? They need to be naked except for a diaper and their sunglasses. We want as much skin exposure as possible so that phototherapy can break down that bilirubin and their jaundice will go away. But of course, there has to be another term, right? If jaundice is left untreated, it can develop into something called kernicterus. It's a funny little word. I'll spell it for you. Kernicterus. Kernicterus. That is the medical term for untreated elevated bilirubin levels, and what you do need to know is that bilirubin will cross the blood-brain barrier, and it can cause brain damage and spinal cord injury. So it can damage both the brain and the spinal cord. Kernicterus is one of the causes of CP, cerebral palsy, which is also one of your topics for this test. So we screen them for it, and then we treat it if needed so that we do not get to the point where we're having some neurological damage. Moving on to feeding method. We can do breastfeeding or we can do bottle feeding. I'm gonna cover some of the positions in SimLab when I actually have a baby and I can demonstrate. So I'm just gonna hit the high points of the differences between breast or bottle feeding. Let's do breast first. Breastfed babies typically eat more frequently, so usually every 1 to 2 hours. Please, please, please tell your moms that their stool is gonna look a little funky. It's gonna be yellow, it's gonna be loose, they do not have diarrhea. That is very typical of a breastfed baby. So yellow, soft, or kind of almost liquidy stools that look like mustard seed is a very common presentation for your breastfed babies. One of the big questions that we always get is, how do I know if my baby's getting enough? And essentially, if they're peeing and pooping, they are getting enough, okay? So that's something that we can educate the moms on. If they are peeing and pooping as they should be, they're getting enough. If they're really apprehensive or have a lot of anxiety or we're having feeding issues, in the hospital, we can get lactation to come in, they can weigh the baby before, we have a special scale, and they can weigh the baby after, and we can pretty much tell how many ounces of breast milk they're actually getting, and sometimes that's kind of enough to alleviate some of mom's fears. Okay? For your bottle-fed babies, they tend to eat a little less frequently, so usually every 2 to 4 hours. Formula feedings tend to cause a little bit more constipation, so their stool is gonna be more formed and they can have issues with constipation. And most definitely with your bottle-fed babies, they need to be burped about every ounce to ounce and a half. With breastfeeding, you don't typically get a lot of extra air, so we usually just, if they're gonna burp them, we burp them in between breasts, but you would not have to detach them from the breast to burp them halfway through the feeding. For little boy babies, we are gonna talk about circumcisions. They do not have to be circumcised. That is the preference of the family as to whether or not they want them circumcised in the hospital. But if they are gonna be circumcised, there's a couple things that we need to know. If they have epispadias or hypospadias, we do not circumcise those babies, because they may need that extra foreskin for the repair. If we are gonna circumcise them, then they do need an informed consent for the parents to sign. And depending on the method that we use will determine how we kind of care for the site after the circumcision. So our hospital uses a Gomco, but I have seen some use Mogan. I'm gonna classify those together, because they're gonna have the same appearance. So you'll know it was done with one of those methods because when they come back, the end of the penis is gonna look really raw and red, okay? If that is the case, we need to put Vaseline on the diaper so that it doesn't stick to the diaper and cause some bleeding, because the penis is very vascular. So we wanna make sure we put Vaseline in the diaper if they use either the Gomco or the Mogan. The other option, which we don't see used much anymore, but in case you see it, is the Plastibell. You'll know it's the Plastibell because it's not gonna be raw and there's gonna be a little clear ring on the end of the penis. That one doesn't require Vaseline. It's not gonna hurt anything to put it on there, but it's not required because there's not anything raw that's gonna come in contact with the diaper and stick, okay? For the Plastibell, that little ring will just fall off. Regardless of the type that they have done, we want to make sure that they void after the procedure so that we can make sure that everything is still working properly. We typically do circumcisions on the day of discharge in the morning before they go home in the afternoon. Questions about circumcision? A lot of your test questions for newborn comes from this slide where we talk about different education and things that we need to teach the parents. There's a lot of education. So I will demonstrate swaddling in SimLab when you come either tomorrow or the next day. Swaddling is usually very comforting for the baby. Remember, they came from an environment that was nice and tight and warm, and now they're in this bright environment, so it kind of mimics being in the uterus at least somewhat. So usually, for most babies, swaddling is very soothing, okay? The bulb syringe, we're gonna teach the parent how to use that. They're gonna depress it away from the baby's face. When they suction the mouth first and then nose with the mouth, they don't wanna go straight to the back of the throat. That's gonna cause them to gag. So they need to go into their cheeks to get all those secretions out. We're also gonna educate them on SIDS prevention, which is another 113 topic. So what are we gonna educate them about?
Side sleeping.
Okay, no co-sleeping,
Prone position, no prone
okay,
position.
no prone position, so supine on their back, clutter-free environment, no smoking in the home, okay? And breastfeeding reduces the risk, so that's always good. All of our babies must have a car seat in order to be able to go home. So we do make the parents bring the car seat up, let them put the baby in the car seat, make sure it's fitted properly, and then we also escort them to their car and make sure that the car seat is fit in the car properly so that the baby is nice and secure. So we do usually ask if they have a car seat, because if they don't, we do have resources to get them one, but they cannot be discharged without a car seat. The other thing that really is more 211 content, but it's come up several times and I've had students ask about it because they see it in clinical. If it is a premature baby, there's something called a car seat test where we put them in the car seat, we put a pulse oximetry monitor on there, and they have to maintain their oxygen saturations for a period of time, usually 1 to 2 hours, depending on the hospital policy for that. So if they're doing a car seat test and you go to the nursery and there's this baby just randomly sitting in a car seat, that's what they're doing. Okay? They have to be able to pass that before they can let them go home. Well, baby checkups are hugely important, so usually before they leave the hospital, we will go ahead and make that first initial well visit for them, and then they can make their visits past that. So we will go ahead and make that for them. There are 3 separate screenings that we do on all newborns. We do a newborn hearing screen, and that's gonna tell us if there's any major hearing issues that we can identify. So let's say they pass it, no problem, we don't do anything different. If they fail it the first time, they will repeat it 1 time just to see if it was a fluke. If they fail it a second time, they will get a referral to audiology for further testing. We're also gonna do a newborn heart, congenital heart defect screening. And this one's pretty simple because there's one congenital heart defect that if you check the blood pressure in the arm and the leg, there's a difference in those blood pressures. So they will at some point in time, you'll go in there and they'll be doing a blood pressure in the arm and then follow the blood pressure in the leg. That's what they're doing. It is not uncommon, because remember when we did your recorded lecture and we talked about the different changes, there are some openings inside the baby in mom that were there on purpose that have to close after the baby delivers. So it is not uncommon to have a little bit of a murmur right after delivery. But if there's anything that is abnormal or suspicious, what test would we do to look at the structure of the heart?
An echo.
Okay, an echo, yeah, ultrasound of the heart, which is an echo. So if there's any doubt, we will do an echo of the heart to see if there's any structural abnormalities or openings that are not supposed to be there. The last screening is gonna be what we lovingly used to call the PKU test. But it is a heel stick that's done on the baby. It is state mandated that we do this. It has to be done after, it can't be done before 24 hours of life. They have to have put food in their stomach and that kind of thing before we can do this test. So usually done at or after 24 hours of life. They do a heel stick on the baby, and they have a little card, it has little circles, and they fill up all the little circles with blood, and that gets sent to the state lab. What this tests for is a wide range of diseases that you've probably never heard of, and hopefully you never will, because if you never hear anything back from that test, it means everything is fine. Okay? It tests for PKU, but it also does test for sickle cell, and it will test for congenital hypothyroidism, along with a long list of like really weird things. Like maple syrup, urine disease, and a bunch of them. Yeah, I know, right? Most of these are metabolic disorders where the baby doesn't process certain things, and if we know about that, then we can treat it, but if we didn't know, it can cause some long-term issues. So if the mom never hears anything back from it, that's a great thing. If it is a positive result, they will call that to the pediatrician, and the pediatrician will get in touch with the mom, and they will get some further testing done. Cord care. So we used to do extensive cord care, but now I'm just gonna tell you what we do. We just look at it. You look at it, you make sure it's dry, you make sure it's nice and clean, it's not draining anything. Just remember that the baby can't be submerged in water until the cord falls off. So until then, it's gonna be just sponge baths and just monitoring that cord to make sure there's not any infection where it touches the skin, because that is a common site that we can see infections in the newborn. Circumcision care we've already covered. Vaccination schedule I'm going to briefly mention with growth and development, although I do not expect y'all to remember that vaccination schedule because nobody does. Daily care, that's gonna include all of this stuff, right? Are they peeing, are they pooping? All babies should void usually within 24 hours and stool no later than 48 hours after delivery. Most of them will do it before then, but they should do it at least by then. That just lets us know that everything's working. And then discharge teaching pretty much includes all of this. How to care for their newborn. Okay? Questions for me? All right, I'm going to skip these first set of practice questions because they are the answers are in the speaker's notes. But I am gonna go over some practice questions that don't have the answers and will allow you to practice some of the things that we did. So I'm a big believer that this is the transition semester where prioritization and delegation becomes hugely important. So we'll be upfront about that. I like prioritization questions. I think it makes you critically think, but it would be unfair for me not to at least expose you to what the question might look like and then expect you to perform on Monday, okay? The other thing that I really like is I love case study questions, and you either love them or you hate them. Most students like them because you have more information and you can make a better informed answer to your question, okay? So I can promise you for this test, there will be at least one case study. So we're gonna do a semi-case study, as well. So, ready? Alright, origin question one. The OB clinic nurse is performing phone triage for the following patients. Which one of the following would have the highest priority? Do not yell it out. I wanna know which one do I need to see first. So read through them and pick which one do you think would have the highest priority or need to be seen or called back first. Ready? Who wants to be brave and give me an answer? Okay. All right, I do like number 3. How many people like 3? Okay, how many people like something else? I think we're like, I'm just not gonna answer. Okay, all right with that. It is 3, let's talk about why. So 26-year-old, she's a gravid at 3, period 0. She is 34 weeks, which makes her preterm. What is the significance of the large amount of clear vaginal discharge? Her water probably just broke, okay? So she is the priority. Who's your second priority?
Yeah,
Yep, I'll take 1. Why?
she's about to go into labor.
Back pain.
Yeah, she's 36 weeks, so that makes her a little less priority than a 34-weeker, and she's having intermittent pains. We need to evaluate her for labor. Okay. What about 2?
She's probably got a UTI.
She could have a UTI, or maybe she just has normal discomforts of pregnancy, right? Remember me saying, make sure you know discomfort versus danger signs. So we do need to rule out a UTI, but it probably is just normal because her baby's getting bigger, it's getting her bladder. What about 4?
She's normal.
That is a consistent finding, right? She's having fetal movement and round ligament pain. So that is more a discomfort of pregnancy. So that is an application-based question about discomforts versus danger signs. The labor and delivery charge nurse is receiving a report on the following patients. Which patient should the nurse see first?
She had that baby come.
Okay, does everybody like 2? It is 2. Let's talk about why. What was the other one that you were kind of stuck on? Okay, 3 is usually the answer that I get. So let's go with 2 first, and then we'll talk about 3. 37 weeks pregnant. When she was admitted, she was in active labor. So she was between 4 and 6 or 4 and 7 centimeters when she got here, and now she's having rectal pressure. It is highly frowned upon for babies to deliver in the bed without any healthcare provider present. And that's what's probably fixing to happen, okay? So that is your highest priority. Now, let's look at 3. If she's contracting 4 times an hour, how far apart are her contractions? Okay? You could literally go have that baby before she has another contraction, okay? That's the reason why. Now, had this said every 3 to 4 minutes, that would have increased her acuity, but you still gotta go deliver this baby first. Okay?
She's 22 weeks.
She is 22 weeks, but at 4 times an hour,
You
she's
can
not
stop
gonna
it.
make quick cervical changes at all. So remember, it's not saying that you're not gonna see these patients, it's just saying if you had to pick which one you had to go see first, because in reality, you're gonna have 4 nurses, somebody can go see everybody, but that's not how the questions work, okay? So deal with the most pressing matter first, and then go from there, okay? What about 1? Do we need to see her?
She can have a baby too.
Yeah, she's gonna have a baby, she is hurting, we need to address her pain, but remember in first semester when pain was almost always the priority, and now in 3rd semester, it's like, hate that you're rated 8 out of 10, but let me go deliver this baby. So that is the reason, we do need to see her, but she's not the highest priority because we expect some pain with labor and she can be a little bit lesser on our list, okay?
So would you see 3 or 1 next?
As it's written right now, I would see 2, and then I would go check in on 1, and then I would check in on 3, and then I would go to 4.
Okay.
Had this been every 3 to 4 minutes, that would have changed. It would have been 2, 3, 1, and 4. Okay?
Yeah, because-
So this could be a ranking question. I could have done it as a ranking question. If I'm gonna do a ranking, I do try to make it a little bit more delineated, okay? I'll be honest about that. What about this patient? What are we gonna do with this patient? She just needs to go home. She's fine. She is our lowest priority. Oop. Hello? Okay. Which of the following patients should the labor and delivery nurse see first?
See,
C,
Why?
it's a late.
because late, he said.
So this is absent variability with repetitive late decels. This is one of your only 3 things that classifies a category 3 stress. That is the highest priority. What is your second priority? B, only because
The detail.
there is a decel there. And then your lowest priority would be A because everything's fine. So this would be a category 3, a category 2, and a category 1.
When I did the fetal heart rate practice quizzes, the only thing that really tripped me up with those is their version of what was moderate and what was minimal.
Yes.
And I was like,
Yes.
you know, they considered, I was like, that's moderate, and then they're like, nope.
No, that's
that's
minimal,
minimal.
yeah. Yes, I will agree that sometimes that makes it very tricky, but for the test, I will try to make it obvious if we're gonna do one. Yeah, it can be, they're sometimes and they're very, very uninclined to give an absent. Very rarely do you see an absent on this practice test. All right, the postpartum nurse is receiving shift report, which the following patient has the highest priorities. This is postpartum. Okay, everybody like 4? It's 4. So she has a boggy fundus, which is abnormal, moderate loci is gonna be abnormal for her, and she has clots, so she has 3 abnormalities, so she is the highest priority. Why is it not 3? Because that's normal for her, right? She's had
And
multiple
she's got 4
deliveries,
babies.
and she's got 4 babies, so we expect her to have some moderate. What about 2? Yeah, so there's nothing else in there that tells me she has an infection, so we have to assume that that is just a normal variation of postpartum period. And then what about 1?
That's normal.
Yeah, that's also normal. We do need to see her. She probably needs some medication, but she is not the highest priority.
She's gonna get some naproxen sodium.
I don't get some naproxen, yep. Which of the following newborns should the nurse assess first following report?
Just seen the grunting.
Y'all better not miss that on the test.
I just seen the grunting.
Yeah, grunting. All right, so 4-hour-old infant, they're tachypnic and they're grunting during respiratory distress. That's gonna be a high priority. What about number 4?
That's the
It's-
next one.
Yeah, that's, well, I mean, and her rate's kinda normal, right? So 110's normal. If she's skin to skin with mom, chances are she's just nice and chilled out, right? Still check in on her, but not the highest priority. 2-hour-old infant with a respiratory rate of 42 and acrocyanosis.
Normal.
That's expected. And then an infant born 4 hours ago with a glucose of 45, we now know that is also normal. Okay? All right, so when we look at a case scenario, so let's talk about how this works for tests. Have y'all had case studies on tests before? Okay, so y'all will work on this. So once you get into the case study, there will be usually 4 to 6 questions. They will be in order, and you will have all your questions related to that case study. It is a continuation of the same patient, okay? So don't forget that. So let's do one for practice. So obviously on the test, you're gonna have the different tabs with the different information. All this is just gonna be on one screen, so it's one, big tab. So, we're gonna go through the information on the right-hand side, but I'm gonna ask the question first, so as we go, we can talk about it. It wants to know which of the following findings would require some type of follow-up questioning or intervention, okay? The fact that she's 28, does that cause us any alarm, any red flags? No. She's a gravid of 4, parent 2, term 1, preterm 1, 1 living.
That's
Okay, I would say that you could probably ask some follow-up questions about that, right? What's going on, that kind of thing. So find out about that. So that would require follow-up. Admitted for induction of labor with oxytocin. Any red flags there?
No.
Okay. She's got lactated ringers infusing at 125. Is that a normal fluid we would use? Now, had that said D10, I would have questioned that. That needs some follow-up. That's a normal fluid. So we typically use normal saline or lactated ringers. We typically infuse that at 125 to 150 milliliters per hour. That's our standard rate. Cervix is 5 centimeters, 100% effaced, vertex, and a 0 station. Any follow-up there?
No.
We could be about to have a baby, right? But there's not anything I need to do about it right now, right?
5 centimeters.
Now, had that said that she was in a breech presentation, that would have absolutely caused some follow-up. Epidural's infusing at 10 milliliters per hour, which is standard, and she has no pain. Any follow-up there? Perfect. She's doing great. What about our vital signs? Any red flags on our vital signs?
Blood pressure. I
Okay,
mean,
the
but
blood
that
pressure
shows
looks
that-
low to me. So even if that's her baseline, that's gonna require some follow-up to see what her normal blood pressure is. But that does look a little low to me.
But isn't it
So-
common with an epidural?
Who knows, right? Reports the history of postpartum hemorrhage that required a transfusion, asthma, and hypothyroidism. Do we have follow-up questions?
Oh, yeah.
For all that, right? What happened? How many blood units of blood did you have to get? Are you being treated for your asthma? When's the last time you used your inhaler? What do you take for your hypothyroidism? All those are gonna require some follow-up. And then our fetal heart rate tracing, is there anything that we need to follow up on? Yes, because she has a D cell. So this would have been a list of options, and we would have picked, gravidapair T-PAL needs to be evaluated. We need to look at her vital signs, her past medical history, and her fetal heart rate. Okay? Nothing has changed. All this on the right-hand side is the same strip and all. The second question is, based on what you see, what is most likely occurring? And it gives you some options. And probably you're looking at me like, I don't know what half that crap means. So how can I know? But we're gonna put it into context. What?
Long active phase.
Could be, but how would we know that? You don't have enough information, it can't be the answer. We don't know how long she's been in labor. What is chorioamnionitis?
It's an infection.
Okay, so even if you didn't know what chorioamnionitis is, if you could just deductively say itis means infection, do we have any signs of infection?
No.
So chorioamnionitis is gonna be an infection of the amniotic sac, essentially. But she doesn't have anything that says that she has an infection. She doesn't have a temp, there's no white count given to us, any of those things. So that's probably not the answer. Epidural side effects?
Yeah.
Okay, so that one looks like a contender, so we're just gonna table it for a minute. What is an abruption?
It's like your heart is just.
Okay, so but it's caused by the
It's for
placenta.
separation.
Yeah, so placental abruption is where the placenta tears away from the uterine wall before the baby delivers,
Which is not that.
which your baby is not gonna know what is,
No.
okay? Because if the placenta tears completely away,
Then you have placental.
then you're gonna have probably fetal bradycardia that's it's just terrible, okay?
Would it be marked?
Usually it's just,
Straight down.
so we don't have any, and we also don't have any vaginal bleeding that would tell us that she's having an abruption, because they will have bleeding as well. Prolonged active phase could be, but we really don't know, we don't have enough time or information to base that on, so probably not that. And then, is she in a coma?
I
So-
hope not.
So we're not that, right? What is this a complication of? Her hypothyroidism, but she's not in a coma, so it's not that one. So we have some low blood pressure, which is an epidural side effect, so that's what's going on. I feel like, SpongeBob SquarePants up here sometimes, but 4 hours later, here's your strip, okay? So if you have a test and you had a strip and the strip changes, now that's what you're dealing with. So this is our current strip. The registered nurse notes the following strip, what actions should be taken at this time, and it gives you these lovely options. And we're gonna pick as many of them as you feel are appropriate. First of all, tell me what's going on my strip. Okay, repetitive variable D cells. Luckily, my variability actually looks pretty good, but I do have some significant variable D cells. So, let's go through the list. Tell me if yea or nay. Do we want to place the patient in a left lateral position?
Always change.
Always change their position. right? Increase the oxytocin to 8.
No.
No. Do we wanna request that he come in and break water? Please do not make this worse. We already got some issues, let's not do that. Administer oxygen by a non-rebreather, and that would be appropriate. Check the patient's cervix, I'm okay with that. Increase the lactated ringers to give a bolus, that would also be appropriate. So we are not gonna increase the oxytocin, and we do not want him to break water. Now, had that said, come to the bedside for evaluation, or give a report to the healthcare provider, that would have been appropriate, okay? So we do our interventions. Are you with me? We did all the things we were supposed to do.
Yes.
Now what it's wanting to know is if you did your interventions and now you have this, was it effective or ineffective? Okay? So if we had a fetal heart rate of 155 to 162 with variable D cells, and now we have a heart rate of 140 to 141, what happened? I went from what type of variability? Moderate, and now I have minimal to absent. Did we get better?
We got worse.
Okay, that is ineffective, our treatment was ineffective. If we had variable D cells and now we have late D cells, we're getting worse. The other two are not related. So for testing purposes, I won't ask you that. I will either ask you, are your interventions effective or ineffective? You okay with that? So we have not been effective, so we need to do some other things. So this is essentially the strip that we just talked about. The absent variability in the late D cell. Now it's saying, well, now what do you want to do? Do we want to place them in a lateral position? Yes, always gonna do what we do. Increase the oxytocin to 10. What do we wanna do to the oxytocin? Turn it off. Request that the healthcare provider come to the bedside.
Yes.
I'm good with that. Administer oxygen by non-rebreather. Check the patient's cervix.
Yes.
Sure, maybe we're crowning and we can have a baby. Administer a fluid bolus.
Yes.
So that's kind of how your case study questions would be worded, or similar, okay? Do that. All right, it is 6:44. Y'all good with me just pushing on? We'll just keep going. We're gonna do a Kahoot for postpartum and newborn, and literally growth and development takes me about 15 minutes. Okay?
Sounds good.
So if y'all are good with pushing on, we'll just keep going.